Today we are just restarting our old sessions, that is the cardiology session, which we were doing in the COVID time. Now I think most of you are confused whether it's going to be next exam or your exam, or it is going to be your exam. Whatever it, while I always emphasize, it's going to be a concept and you want to learn the concept, you can excel in any other exam, whether it's going to be university or whether it's going to be a next exam. In this regard, I welcome our today's mentor, Dr. Rashmi Shivram ma'am. She is a well-known teacher who has already taught you all cardiology through our forum. And today we are going to have an excellent session from her on the topic. We have regular session in our channel, and I with us your introduction to you, ma'am.
Hello, can you hear me?
Yes, ma'am.
Yeah. So very good evening to everyone here. So I'm very happy to be back. We had been taking some cardiology chapters earlier. So I would be happy if you can all go back and listen to those chapters, and you can come back with some doubts. And also you can let me know like what kind of classes that you would want, so that we can go on those lines. So whether it is next, or as Dr. Raghu said, whether it's next or whether it is the final year exams, all are the same. So you need to know the concept. So among that, hypertension is a very, very important topic for your final year exam, as well as for your MCQ questions. You've often seen very long questions on hypertension, and you need to deduce, you need to find out very few points which will actually help you in coming to the conclusion and actually marking your MCQ. So in medicine, we cannot go by ambiguity. So we need to be clear as to what each and every topic is and what each and every target means. Okay, so let's go into the topic of hypertension. So I hope I'm audible to all of you.
Yes, ma'am.
Yeah. Okay. Shall we start?
Yes.
Okay. So let us start with the basic question actually. So we'll come back to answering this question in the end, but I want you to keep this in your mind. Okay, so that you can ponder on the topic, on the signs that I have mentioned here. Okay, let me read this out to you. A 25-year-old lady with no significant past medical history came to the clinic for follow-up. Her regular BP recordings were 160 on 100 millimeters mercury. Cardiac examination is completely unremarkable, and all her pulses were equally full. There were no signs of peripheral edema. On lab evaluation, plasma renin activity was low, and her serum creatinine levels were normal. On CT abdomen, bilateral enlargement of the adrenal glands were noted. So which of the following serum lab values are we likely to see in this patient? So what will be the sodium, potassium, and the pH? Will it be high, normal, or low? So what will be the sodium, potassium, and pH values? We shall come back to this question in the end. Okay, I hope this discussion will be useful for all of you. Let's continue. So first, starting with the basics. So we need to know how we record a BP and what is the correct way of recording a BP. So this is a very beautiful picture given by the American Heart Association. So when a patient comes into the clinic, when he sits and when he starts talking to you, he is bound to be anxious. So what we must do is, the room should be quiet, the room should be very comfortable, and you should make sure that the person is sitting straight with the back supported, and his legs should be flat on the floor. So what should not happen is, the person should not be crossing his legs or leave his legs dangling. So what should happen is, the feet should be flat on the floor, and you should select an appropriate cuff size. So how do you select an appropriate cuff size? We all studied this, but we may tend to forget. So let's revise that. So the length of the cuff should be at least 80% of the, should cover 80% of the circumference of the arm. Okay, so the length should cover at least 80% of the circumference, and the width should be at least 40% of the arm. So the length should be at least 80% and the width should be 40%. So the cuff size is very, very important. As we all know, if the person is suffering from some catabolic disease like cancer and is in terminal stages, is bound to be very cachectic. In that patients, you cannot use a cuff which is normally used for an adult. So we need to use probably a pediatric cuff, which will suit him better. Okay. Likewise, in obese patients, if you try to wrap around the cuff may not be even enough for the patient. In such situations, what happens is the BP recordings will be erroneous. So we should choose an appropriate sized cuff to actually record the BP. Okay. The person should have an empty bladder and the person should be well relaxed before recording the BP. So as soon as you come in, as soon as the patient comes in, you take 3 BP recordings and you take an average of the last 2. Okay. Average of the last 2 recordings so that the BP is more accurate. Okay. So what happens when you record the BP? Actually, you inflate the cuff, isn't it? Once you inflate the cuff, the artery becomes occluded. If this is the artery, it becomes occluded. So when you keep on releasing the cuff, what happens is the artery slightly opens and then it becomes fully patent. Okay. The point when it starts releasing, when it starts opening, that is the first sound that you hear, and that is the systole. That is the systolic sound. When the artery first opens, that is the systolic sound. As you gradually keep decreasing the pressure, the artery begins to expand further and comes to its normal size. So in that case, the sound disappears. That is the diastole. So diastole is the disappearance of the sound, and the systole is the first occurrence of the sound. It is because we are occluding the pressure in the artery and then releasing it gradually, we are getting these sounds. These sounds, as we all know, it is called the Korokov sounds. So I would like you all to know this physiology behind the recording of the BP. Okay, so that will be very useful for you. Okay, and the person should not have had any smoking or any coffee or any vigorous exercise at least 30 minutes before recording the blood pressure. Okay, so how do you record the blood pressure? So when the patient comes into when you see a patient, you should record BP in all the 4 limbs. All 4 limbs BP is very, very important. All 4 limbs BP is very, very important. Why is it important? Do you expect any variation between the limbs? Yes. So what happens is, between the upper limbs, there is usually a variation of around 10 millimeters mercury. How much is it? Between the upper limbs, between our 2 upper limbs, even in normal people, the variation is around less than 10 millimeters mercury. Okay, suppose you find that the variation is more than 10 millimeters mercury. So what does that imply? So if the BP in, suppose my left arm is 200 on 100 and the BP in my right arm is around 130/80. So what does this mean? This means that there can be an aortic dissection. There are 3 conditions generally that we talk about when the BP, when one upper limb is different from the second upper limb. So one is aortic dissection. There can be a peripheral arterial disease. So because of the occluding, the BP can be high. So one is aortic dissection, second is peripheral arterial disease, and the third one is subclavian steal syndrome. Okay, what is this? Subclavian steal syndrome. So this is very important. Okay, so we should record the BP in all the 4 limbs. The difference between the upper limb BP will be usually less than 10 millimeters mercury. If it is more, it means that the person can have some conditions like aortic dissection or a peripheral arterial disease or a subclavian steal syndrome. So what about the lower limb BPs? Okay, so the lower limb BP is in normal people also, the difference between the upper limb BP and the lower limb BP is around 20 millimeters mercury. Okay, how much is it? It is around 20 millimeters mercury. So when this difference becomes higher, in which case, where do we find that the lower limb BP is lower than the upper limb BP? In condition called coarctation of aorta. Coarctation of aorta. So what happens in this? There is a block at the level of the aorta at few locations in the aorta. Because of that, the blood supply to the lower parts of the body is less. So the lower limbs BP becomes lesser and the upper limbs BP are normal. So when this variation is more than 20 millimeters mercury, then there can be a condition called coarctation of aorta. So we need to keep this in mind that if there is any young patient who has a difference of more than 20 millimeters mercury between the upper limb pressure and the lower limb pressure, then we should definitely keep the option of coarctation of aorta in our mind. We should keep the diagnosis in our mind. So it is very, very important, and we should make it a habit that we examine the BP in all the 4 limbs without any bias. Okay, we should not just assume that the BP recorded in the left upper limb is always correct. Okay, we should record the BP in all the 4 limbs. That is very, very important. Next, moving on, why do you think controlling BP is very important? So why should we control BP? What will happen if the person continues to have a high BP for a very long time? So BP is very, very important. Like we all know, in diabetes, controlling HbA1c levels are very, very important. Like that, controlling the BP levels in hypertension is very, very important, because when you reduce the systolic blood pressure by 10 millimeters mercury, and when you reduce the diastolic blood pressure by 5 millimeters mercury, you significantly reduce the risk of coronary artery disease and stroke. You will be surprised to know by how much it decreases. The risk of CAD and stroke decreases by nearly 40 to 50%. This is a very good thing. Say you reduce the BP from 150, 90 to 140 by 80. That means you're reducing the risk of coronary artery disease and stroke by 40 to 50%. So given the benefits that controlling the BP can give, we have to work on it, and we have to make sure that all our patients are having optimal control of BP. That is very, very important. Okay, because we don't want these comorbidities to turn into life-threatening emergencies. Okay, so it's very, very important that we control the BP. Okay, so now moving on to how we classify hypertension. So what we do is we divide the hypertension based on the phase of the cardiac cycle or based on the etiology. If it is based on the cardiac cycle, we say it is either systolic hypertension or diastolic hypertension. Based on the etiology, it is primary or secondary. We find that nearly almost 90 to 95% patients have primary hypertension, and only around 5 to 10% patients have secondary hypertension. But nowadays, we find that the percentage of secondary hypertension is actually increasing. And what is more interesting is that almost all of your MCQ questions based on hypertension will more likely be in the secondary hypertension, because they tend to give you more clinical findings and ask you what can be done and how you diagnose and reduce the answer. So secondary hypertension becomes very important in terms of your MCQ and thing actually. But even in your practice, what happens is secondary hypertension is very important, because you don't want to miss any patient with secondary hypertension. Okay, which can be diagnosed and treated. The patient need not be on lifelong drugs if you are able to control the secondary hypertension factors. Okay, so it's very, very important that you diagnose the patients with secondary hypertension. You keep a very keen eye and observe like who has the secondary hypertension. It is very, very important. The primary hypertension is already called essential hypertension. Now we term it as primary hypertension. Okay, so how do you define hypertension? So there are many associations so far who have given definitions for hypertension. Until now, we have been following the JNC 7. Like all of you must be familiar. That's the Joint National Committee 7 and the AHA guidelines, American Heart Association guidelines. So JNC 7, this Joint National Committee has now been dissolved. Okay. And now we use a different guidelines. So you can use whatever you want, but whichever you find is appropriate. Right now, we all follow the European Society of Cardiology guidelines. So just to give you a relevance for what we have been using so far. So what the JNC had defined, there was something called pre-hypertension. Okay. So patients who have BP between 120 to 140, those were termed as pre-hypertension. Those were called as pre-hypertension. And stage 1 hypertension was only more than 140. So more than 140, it was stage 1. Okay. So, but what happened was in the 2017 AHA guidelines, they actually reduced the cutoff for the hypertension. So what happened was more people were included under the bracket of hypertension. So what they did was stage 1 hypertension was defined. Stage 1 hypertension was defined when the BP was more than 130 itself. Okay. So what happened was more patients came into the bracket of hypertension. So why is this classification actually important? Why is this staging important? This staging is important because we want to find out the treatment guidelines. Okay, we want to find out how to treat the patient. So for that, this staging of hypertension is very, very important. Okay, so this was what we have been using so far. This is pre-hypertension. You need to remember these terms: pre-hypertension, stage 1 hypertension, and stage 2 hypertension. Okay, next. Before we move on, we'll come to some terms that we need to know. Like you all know, office BP. Office BP is nothing but the BP that we record when the patient comes to our clinic or in the hospital that we record. That is called the office BP. Okay, the office BP usually tends to be a little bit higher. Okay, so because the patients tend to be anxious when they come to the doctor, so the office BP tends to be higher. What is ambulatory BP? Ambulatory BP, it is very, very important. Okay, it is a new concept. I mean, it's not very new, but we are using it more often right now, and it is now used to diagnose hypertension. This has become very important in diagnosing hypertension. Okay, ambulatory blood pressure is just a monitor. It's a device that you connect to the patient and you just put it on for 24 hours. You leave the patient on the ambulatory blood pressure for 24 hours. It actually records at regular intervals. You can set the intervals, say between 15 minutes or half an hour. It records the BP on its own. And once you put it into the software, you get the report. Okay, so why is this important? This is very important because you get a graph on that ambulatory blood pressure recording. This is a graph between the time and the blood pressure, SBP or DBP, systolic blood pressure or the diastolic blood pressure. So when you see this graph, what happens in normal individuals is, say you put this on for the patient at around 9 p.m. in the night. This is 10 p.m., 11 p.m., 12 midnight. Okay. Then 1, 2, 3, 4 o'clock in the morning, 5 o'clock in the morning, 6 and 7. So what happens is the BP recordings tend to decrease at night. Even for normal individuals, the BP recordings are like this and they tend to decrease in the night and there is an early morning surge. What is this? There is a dip in the night and there is an increase in the morning hours. Why does this increase happen? The increase is because of the hormones that are secreted, mainly because of the cortisol hormones. As we all know, at around 8 a.m., the cortisol hormones are the highest, are peaking. They are the highest levels. That's why the BP increases towards the morning. But at night, the BP drops in normal individuals. This dip is called nocturnal dipping. What is this called? Nocturnal dipping. This is a very important term that you need to know because the first stage in a hypertensive patient, this nocturnal dipping will be lost. Okay. The first stage in the hypertensive patients, you will find that the nocturnal dipping is lost. So the patient may come to you, he may have BP between 130-80. So when you put on the blood pressure, you will find one ambulatory BP, you will find that the nocturnal dipping is lost. That means that the patient is progressing into hypertension. So the first sign that you can find out that the person is becoming hypertensive is there will be no nocturnal dipping. Okay, so this nocturnal dipping is a normal phenomenon that happens in normal individuals. If it is lost, that means the patient is hypertensive. Okay, so I hope you will remember these two terms. One is nocturnal dipping and the other thing is early morning surge. Okay, early morning surge. So this ambulatory BP actually helps record the patients in a less anxious environment at the comfort of their house. So when the BP is less than 135, is more than 135, or more than 85 diastolic, when the systolic is more than 135 and the diastolic is more than 85, you label the patient to be hypertensive. On the ambulatory blood pressure, if the patient's BP is more than 135 and if the diastolic blood pressure is more than 85, then you diagnose that the patient has hypertension and you need to treat the patient. Okay. So next term is white coat hypertension. What is white coat hypertension? This is a very famous term and you will also find it in some of your MCQs. When the patient comes to you, he's very anxious. So his BP recordings are very high. Office BP will be high. Okay. But when you put the ambulatory blood pressure will be less. Okay. Will be normal. He'll be normotensive at home. So this is white coat hypertension. What is masked hypertension? It is the reverse of white coat hypertension. What happens is the ambulatory blood pressure will be high. Ambulatory blood pressure will be high. Whereas his office readings, when he comes to you for consultation, the BP will be low. So this is called masked hypertension. So I hope you've understood this. Ambulatory blood pressure, this is very important because we now use that as a tool for diagnosing hypertension. We use that regularly. You have to put the patient on ambulatory blood pressure and show when his BP rises throughout the day so that you can adjust the medicines also accordingly. So loss of nocturnal dipping is seen in hypertension. Okay. And nocturnal dipping is a normal phenomenon in normal individuals. Okay. If the BP is more than 135 systolic and more than 85 diastolic, you diagnose that the patient has ambulatory has hypertension in the ambulatory blood pressure recordings. Okay. Next, moving on. So what we actually follow now is what the European Society of Cardiology has given. Okay. So they have defined something called optimal BP. Okay. What is it? It's called optimal BP. Optimal BP. Optimal BP is when the systolic is less than 120 and the diastolic is less than 80. Optimal BP is when the systolic is less than 120 and the diastolic is less than 80. Okay. So after that, we define what is normal BP. Normal BP is between 120 to 130 and 80 to 84. Okay. If the systolic blood pressure is between 120 to 130 and the diastolic blood pressure is between 80 to 84, we say that the person has normal BP. Okay. And what is high normal? High normal is after that, between 130 to 140 and between 85 to 90. Okay. So if the person has BP between 130 to 140 and the diastolic BP between 85 to 89, it means it is high normal. It is high normal. Okay. So these are very, very important terms that you must know. Then once the BP crosses 140, we grade that person to have hypertension, grade 1 hypertension. Okay. So grade 1 hypertension is when the patient's BP crosses 140. Okay. You need to remember that when it crosses more than 140. Okay. Then comes grade 2 hypertension. If it is more than 180 or more than 110, then we say that the person has grade 3 hypertension. It's called grade 3 hypertension. So you give drugs, but when do you say that the person has secondary hypertension? When will you suspect secondary hypertension in a patient? You must know this because it's very, very important. When will you diagnose secondary hypertension in a person? Any ideas? Can you all tell me? When will you diagnose secondary hypertension in a patient? When will you find out? Please, I hope you can be interactive so that we can discuss and learn. Yes, guys, can you tell me when will you suspect secondary hypertension in a patient? So you will suspect secondary hypertension in a patient when the age is very less, when the age is less than 30 years. Okay. So if the patient is around 30 to 35 years or less than that, and the patient is found to be hypertensive, you will diagnose secondary hypertension. You will suspect secondary hypertension in that patient. Okay. The second point is when the patient has resistant hypertension. Yes, when the person has resistant hypertension. Okay, what do you mean by resistant hypertension is when the person is on 3 drugs, but still the hypertension is not controlled. Okay, and the 3 drugs should include thiazides. That's a diuretic. Okay, so first the age should be less than 30 years. The person should have resistant hypertension. Okay, then you will suspect secondary hypertension. Or the patient should have an abrupt or accelerated hypertension. Abrupt or accelerated hypertension. Okay, so when the person comes to you with an abrupt or accelerated hypertension with endogen damage, then you will suspect when the person comes to you in the first setting with an accelerated hypertension with endogen damage, then you can suspect secondary hypertension in that patient. Okay, then the fourth point is when the person has palpitations, headache, or sweating, which are, as you all know, this is, you will suspect pheochromocytoma in this patient. So palpitations, headache, or sweating. When the person has palpitations, headache, or sweating, then you will suspect secondary hypertension in this patient. Okay. Then what is the fifth point? When the person has abdominal bruise. Abdominal bruise. So you may not be familiar with this one. So when the patient has a renal problem, renal hypertension, renal induced hypertension, then the patient may have some abdominal bruise. renovascular hypertension, the patient has abdominal bruise. So examination becomes very, very important in patients with hypertension. So you need to find out, and you should always be very observant and find out if the person has any signs of secondary hypertension, which can be corrected, which can be treated. So it's very, very important in whom you are suspecting secondary hypertension. Okay, suppose a patient walks to you, he is around 35 years and you find that he is hypertensive with no family history, or if there is a family history also, you should not immediately conclude that it is only essential hypertension or only primary hypertension. You should be observant and keep in your mind that this could be secondary hypertension also. Okay, so that is abdominal bruise. Then the sixth point is, if the person has central obesity or purple striae, all of you must be familiar with this one, or a moon face, or buffalo hump. Okay, all this is Cushing's disease. So if all these are there, then you can suspect secondary hypertension. Then one more is, if the person has some metabolic abnormalities like hypokalemia plus adrenal enlargement. Okay, when there is hypokalemia and adrenal enlargement, then this patient you can suspect secondary hypertension. So when will you suspect or keep in mind an option of secondary hypertension is when the age is less than 30 years, when the patient has resistant hypertension, when there is an abrupt or accelerated hypertension with endogen damage, when he has palpitations, headache or sweating, when he has abdominal bruise, when there is central obesity or purple striae, buffalo hump or a moon face, and the patient has hypokalemia or adrenal enlargement, it is very important to keep the secondary hypertension in mind. So when you think about secondary hypertension, what are the causes that you will consider? So first will be renal causes. Okay, renal. Hypertension in kidney patients, it will be a cause as well as effect. So a kidney issue can cause hypertension, as well as a hypertension can precipitate a renal issue. Okay, so it is like a cause and effect can happen in renal patients. So what happens is there are two conditions. It can be a renal parenchymal disease or a vascular disease. Renal parenchymal disease or a vascular disease. So vascular disease, which is renal artery stenosis. Okay, renal artery stenosis. So renal artery stenosis, you have to remember, is very, very important. It is very frequently asked in your MCQ questions. Okay, so renal parenchymal disease or renal vascular disease, which is renovascular hypertension as we call it, happens in renal artery stenosis. The second causes are endocrine causes. Endocrine causes. Among these endocrine causes, we have pheochromocytoma, then Cushing syndrome, and you have so many causes. Okay, and the third one, the most important that you have to remember, which is happening more and more frequently right now, is the obesity hyperventilation syndrome. Hyperventilation syndrome. Okay, so this is very, very important. As the incidence of obesity increases, we find that obesity hyperventilation syndrome, or the obstructive sleep apnea, which happens in these patients, it actually precipitates hypertension. You find that hypertension is a major component in this complex of symptoms. Okay, so you need to keep in mind the patient need not be completely obese or morbidly obese alone to have obesity hyperventilation syndrome. It depends on the neck circumference and so many other factors. When the patient has an obesity hypoventilation syndrome, you should be very keen and find out if the patient has hypertension also, which will most commonly occur. So let's now have a look at what are the secondary causes of hypertension that we are going to see. First is the renal disease, like I told you. First is renal parenchymal disease and renal artery stenosis. Renal artery stenosis. Okay, this is a very important factor because you find that when there is renal artery stenosis, the patient goes into flash pulmonary edema, and that is like an endogen damage. So the patient presents with accelerated hypertension and pulmonary edema, the patient may be having a renal artery stenosis, which may not have been diagnosed earlier. Okay, so we need to keep this in mind that renal vascular disease or renal parenchymal disease can cause secondary hypertension. Okay, so then what are the endocrine causes that can cause secondary hypertension? We have seen pheochromocytoma, Cushing syndrome, primary hyperaldosteronism, which is very, very important. Then glucocorticoid remediable hypertension, hyperparathyroidism, acromegaly, hypo as well as hypothyroidism. Both hypo as well as hyperthyroidism, both can have hypertension. What happens in hypothyroidism is there is mixed edema. Okay, that causes mixed edema causes hypertension, whereas in thyrotoxicosis, it is because of the elevated thyroid hormones that there is a hyperdynamic circulation and there is a hypertension, congenital adrenal hyperplasia, as well as Liddle syndrome. These are all very, very important. You need to keep this in mind because these are very, very common options that you will be seeing in your MCQs. Okay. Then coming to the drugs, we have estrogens, anabolic steroids, NSAIDs, then sympathomimetic agents, and the others are most important, obesity. In obesity, we have the obesity hypoventilation syndrome or the obstructive sleep apnea syndrome. In that, it is very, very important to remember now the incidence is increasing. So hypertension is a major, major factor of this complex and it needs to be identified and treated. Once you treat the obesity hypoventilation, hypertension actually comes to control very drastically and very dramatically. So we need to keep that in mind. Okay, next is the coaptation of iota and pregnancy. Okay, in pregnancy also there is a component of hypertension, that is preeclampsia. We need to remember that, and we need to look out on keep on the watch and find out whether the pregnant lady develops hypertension, especially more if it is high risk pregnancy. Okay, so you have diagnosed whether it's primary or secondary. Then how do you treat this patient? Okay, you've seen whether it's systolic hypertension or it's a diastolic hypertension. So how to treat and when to treat? You must remember that whether it is stage 1 hypertension, pre-hypertension, normal hypertension, whatever it is, the first thing that needs to be done is lifestyle modifications. Okay, irrespective of the stage of hypertension in which you diagnose the patient. So the patient may come to you when he has BP of 180/100, or he may come to you when the BP is 129/80. Okay, so irrespective of when he comes to you, lifestyle modifications are very, very important. And we find that most often just weight reduction alone actually decreases the BP drastically. So if the person is around 85 kgs and he drops to his ideal weight, then actually his BP may improve by around 10 millimeters mercury, which is actually very, very significant. And it avoids using medicines in that patient. Okay, so the first step is lifestyle modifications. So what are the lifestyle modifications that you will suggest to your patients? First thing is weight reduction. Okay, weight reduction is very, very important. Okay, first is weight reduction. If you are in the normal BMI range and if you reduce the reduce the weight by 10 kgs, you can actually improve your BP by 20 millimeters mercury. 10 to 20 millimeters mercury you can improve. Then comes the DASH diet, which includes eating low fat, lean meat, and high fruits and vegetables and low dairy products. All these, if you advise the patient, then they can have a better control of blood pressure. Then there should be some dietary sodium restriction. Slightly lesser salt intake should be there. And you should definitely advise physical activity. Aerobic physical activity is a very, very important thing. It's just physical activity, not just walking, regular walking. You need to do some jogging or running. It should be some form of aerobic exercise that will actually improve your BP. Okay. Then alcohol consumption should be restricted. So the major points that you will advise the patient is first weight reduction, giving a DASH diet, then advising dietary sodium restriction, giving physical activity, which is aerobic physical activity, then alcohol consumption should be reduced. All these will improve the BP, but the major factor and the first one that will improve the BP to a maximum extent is weight reduction. So weight reduction is very, very important in all the patients. Okay, so let us see how we are going to treat the patients. So the first thing is, according to the European Society of Cardiology, if the BP is 120 or less than 80, then it is normal. Okay. And if the BP is between 120 to 129 or less than 120 to 129 or less than 80 and less than 80, or if it is between 130 to 139 and 80 to 89, the next category will be 140 to 159 and 90 to 99. The third will be more than 160 or more than 100. Okay. So if the patient is having blood pressure more than 140, you will definitely start the patient on drugs. Okay. If the patient comes to you with BP on ambulatory blood pressure, say 150 on 100 or 150 on 90, then you will immediately start the patient on drugs. Okay. Along with lifestyle modifications, of course. Okay. But if the patient has BP between 129 and 130 or 140, between 120 to 140, if the patient has BP, and how are you going to manage this patient? So what you should do is, there is something called the ASCVD risk score. Okay. ASCVD risk score. You have to do this risk score, which is an online tool. You do this and you find out the 10-year mortality risk. Okay. 10-year cardiovascular risk. Okay. 10-year cardiovascular risk. 10-year cardiovascular risk. If this cardiovascular risk of 10 years is more than 10%, even if the person has BP as less than 130/80, then you need to definitely give the patient drugs. Okay. So if the person's BP is around 130/80, but his 10-year cardiovascular risk is more than 10%, then you should start the patient on medications. This is very, very important. This ASCVD risk score is now gaining a lot of importance and we are using it regularly. If the person has BP more than 140, you definitely treat the patient with drugs along with lifestyle modifications. But if the BP is slightly lesser, but his cardiovascular risk, as according to the ASCVD risk score, is high, it is more than 10%, then you definitely need to start the patient on drugs or medications. Okay, do you understand? So if it is more than 140, you definitely need to give the patient medications. So what are the medications that we will be using? So this is the ASCVD risk score. It is an online tool which measures the age, the sex, the race, systolic blood pressure, diastolic blood pressure, the total cholesterol, HDL cholesterol, LDL cholesterol, your history of diabetes, smoking, aspirin therapy, all the drugs that you take, and whether you're on hypertension or not, hypertension treatment or not. These factors actually estimate the cardiovascular risk that you have. And if your 10-year risk is more than 10%, then you should definitely put the patient on medications for controlling hypertension. Okay, I hope it is clear. Yeah, so we have seen for all patients, irrespective of the stage that they come to you, lifestyle advice or lifestyle modifications are very, 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 very important. We have seen how much weight reduction helps in reducing the BP. And if it is more than 140, then you definitely start the patient on drugs. Okay. If it is more than 140, you definitely start the patient on drugs. So what are the medications that we use? So let us remember something like A, B, C, and D. Okay, that is what we use. The first one is A, means AC inhibitors or ARBs, like telmisartan, losartan, and enalapril, captopril, all those things in AC inhibitors. ARBs, telmisartan, losartan. Okay, then B is beta blockers. C is calcium channel blockers, and D is diuretics. Okay, so A is AC inhibitors, ARBs, B is beta blockers, C is calcium channel blockers, and D is diuretics. So you have this wide range of antihypertensives to choose from. But which are the antihypertensives that you will choose? Okay, so before we go to the antihypertensives that we'll choose, I would like to tell you some small concept. The thing is, we know that hypertension is actually measured by cardiac output into the peripheral vascular resistance, isn't it? So we should be aware that increasing the if the patient has cardiac, the hypertension is directly proportional to cardiac output. So if the cardiac output increases, hypertension will increase. If the systemic vascular resistance increases, then the hypertension will increase. So what we do is, to reduce the hypertension, we actually reduce the systemic vascular resistance. How do we decrease the systemic vascular resistance? We give vasodilatory drugs. If there's vasodilatation, like calcium channel blockers, they vasodilate. AC inhibitors, they vasodilate. Because of that, the hypertension reduces. So we need to remember that this is the mechanism by which most of the antihypertensives act. Okay, so AC inhibitors, ARBs, beta blockers, calcium channel blockers, and diuretics. So earlier we used to say that beta blockers or the diuretics were the first line of drugs. Earlier, these were the first line of drugs in earlier days. Now what we say is the first line is either AC inhibitors or calcium channel blockers. Now we use either AC inhibitors or calcium channel blockers as first line medications for treating hypertension. Okay, and though we have a wide range, we need to choose very wisely in which patient what drug we have to use. Okay, we need to identify in which patient which drug we are going to use. Okay, do you understand that? Yeah. So the first thing we'll now, before going into where we use these drugs, we'll find out what are the side effects of common side effects of these drugs, so that it will be a small revision of the pharmacology also. So the major side effect of AC inhibitors and ARBs is cough. Okay, you all very well know that is because of bradykinin accumulation. So AC inhibitors must be avoided in patients who have cough as a side effect. Okay. And they should be switched on to ARBs. ARBs don't produce this cough. Okay. The next thing is beta blockers. They are contraindicated in asthmatics or COPD patients. Okay. They are contraindicated in asthmatics and COPD patients because they cause bronchoconstriction. Okay. And they will precipitate an asthmatic attack. So calcium channel blockers are generally safe, except like few drugs like amlodipine, which will cause pedal edema. But we have newer agents like cilnidipine or nicardipine, which does not have any pedal edema. Nowadays, the pedal edema producing drugs have become rarer. So the calcium channel blockers have become more and more effective, and we use them as a first line drugs, okay, along with AC inhibitors. Then diuretics, they cause some metabolic disturbances like hypokalemia. Okay. Hypokalemia is a very, very important side effect of diuretics. So it is very important in whom we choose these drugs. We should choose these drugs very, very effectively so that the patients benefit from your drugs and you do less harm to the patient. Okay. So let us see this. So first, the dual dose combination. The first step will be A plus C. The first step will be A plus C. Then you will actually optimize the doses. Suppose you start the patient on telmisartan 40 mg, then you can actually go up to 80 mg and optimize the dose so that you will find the effect is there or not. If not, then you add one more drug, which is called D. That is a diuretic. You add a thiazide diuretic. Earlier, we used to use drugs like chlorthalidone and hydrochlorothiazide. Now we use indapamide. Indapamide is a good drug to actually reduce the hypertension, and it is quite safe without most of the side effects of the diuretics. It is safer among the lot. Okay. So first we add an angiotensin converting enzyme inhibitor or ARB along with a calcium channel blocker. Then we actually optimize the doses. Then we add a third agent, which will be a diuretic. Okay. Suppose the patient is not responding to all the three drugs. That is when we label the patient as having resistant hypertension. Okay. The patient is having resistant hypertension. So what does it mean? It means that the patient is not responding to three drug combination. That is AC inhibitor or ARB plus calcium channel blocker plus diuretic. Then the patient is said to have resistant hypertension. In that case, we can add a spironolactone or a beta blocker. Okay. Spironolactone or a beta blocker. In this patient, what should you remember? You should remember that secondary hypertension can be the cause for this resistance in the hypertension. So you need to keep an eye and look out for secondary hypertension causes in this patient. Okay. So resistant hypertension is very, very important concept that you should need to remember. Okay. So what are the targets that we think? What are the targets that we use to treat the patient? Okay. So you have seen so many things. What do you think that we actually follow in India? We follow the Indian national guidelines. Indian guidelines for hypertension that we have. 4th guidelines have been released. Okay. There is something called the Indian guidelines. In that, what we do is, in patients less than 60 or 65 years, 60 to 65 years, we have a very strict cutoff, okay? Strict control of BP. But more than 60 or 65 years, we tend to relax it a bit. If the patient has more than 140, we do accept the BP. Relax, okay? Relax the control, okay? But it should not be too high. It should not be more than 150 or 160, but you should not keep it very less than 120 or less than 130. That is not advisable in patients more than 65 years. Okay. In patients less than 60 or 65 years, we should have a very strict control, say the control the BP between less than 130 or less than 120. Okay. But in patients more than 65 years, we need to relax the hypertension control. We can have it at around 140-90. Okay. So this is very important according to the Indian guidelines. So, and also one more thing that we have to remember is, if the patient has some cardiovascular risk or is already having something like a coronary artery disease or a stroke which has already occurred in that patient, in those patients, you need to have a strict control. Okay. You need to have a strict control of hypertension in those patients. So what do you mean by strict control? It should be less than 130/80. Okay. So BP should be less than 130/80 in those patients when there is an increased risk of cardiovascular risk. If the patient is already having a coronary artery disease or a stroke. Okay, if he has already had all those things, then you should have a strict control. If the patient is having a comorbidity, then you better control the BP more strictly. Okay. In younger patients, you need to have a stricter control. In older people, you can actually relax the control a little bit. Okay. So there are some conditions that we will actually see where you will have to find out what are the first line of drugs that you should select. So in black patients, we have seen that we don't generally use an AC inhibitor or ARB. In these patients, the first line of drug will be a calcium channel blocker. Okay, the first line of treatment will be a calcium channel blocker or a diuretic. We don't generally use an AC inhibitor or an ARB in black patients who develop hypertension. Okay, suppose the patient is having hypertension with proteinuria. As we all know, angiotensin converting enzyme inhibitors, AC inhibitors or ARBs are very, very effective in controlling proteinuria. So AC inhibitors or ARBs, these are the first line drugs in controlling hypertension and proteinuria. In patients with hypertension and diabetes, what would you select? Again, AC inhibitors or ARBs, because diabetic patients go on to develop diabetic nephropathy and proteinuria. So hypertension and diabetes, they will develop proteinuria. So AC inhibitors or ARBs are very, very important. Then hypertension and heart failure, beta blockers are very, very effective. Okay, hypertension and heart failure, beta blockers are very, very important. Again, hypertension with any cardiac issue like atrial fibrillation, angina, essential tremors, definitely beta blockers are the mainstay. Okay, beta blockers are very, very important. And if the patient is having hypertension with COPD, like I already told you, beta blockers are contraindicated. So you can use the other drugs. Beta blockers are contraindicated. So you will use AC inhibitors. No, AC inhibitors can actually cause more cough. So you will also not give AC inhibitors. No beta blockers. Okay, so you should use a calcium channel blocker or a diuretic. Okay, so calcium channel blocker or diuretic can be used in these patients. So these are some special conditions that you should remember, because when you get an MCQ, you will have these points. When you identify that the patient, they have given some history of proteinuria or they have given a history of diabetic nephropathy and the patient has hypertension, they will ask you what is the drug of choice. Or the patient has hypertension along with some cardiac issue, they will ask you what is the drug that you will prefer. Or in a patient with COPD, they might ask you what drug is not advisable. So in these conditions, if you remember all these points, it is very easy for you to solve the MCQs. Okay. So this is a small table. I would like to show you, highlight something. I told you that when the patient has, other comorbidities, you need to control the BP more strictly. But the exception is patients with CKD. In patients with CKD, you should actually relax the BP a little bit because they have more chances of hypotension also. So if the patient is having CKD, the BP should be less than 140. You need not have a very strict control of less than 120 or less than 130. You can have a BP control at around 140. Okay. So moving on, what is emergency and urgency? What is hypertensive emergency and what is hypertensive urgency? So what do you mean by that? If the BP is more than 110, 180 by 120, okay? If the BP is more than 110, 180 or BP more than 120, this is just a cutoff value. But remember, if the patient has a value more than 160 or 100 also, and the patient is coming to you with an end organ damage, then you still consider it as an emergency. So what is emergency? Emergency is accelerated hypertension with end organ damage. End organ damage. Okay. What is accelerated hypertension with end organ damage? That is hypertensive emergency. So what is hypertensive emergency? It is accelerated hypertension with no end organ damage. Just increase in hypertension. Okay. And no end organ damage. That is urgency and emergency. Okay. So accelerated hypertension with end organ damage. So what do you mean by this end organ damage? What do you think what comes to your mind when you think about end organ damage? The most common ones that we see is the patient can have very severe headache and the patient will have papilledema. Okay. That is a effect in the eye. There is an end organ damage in the eye. The person has papilledema. Okay. Then the patient can present to you with a stroke. The patient can present to you with a heart failure. The patient can present to you with a MI, angina and MI. Okay. Or the person can have aortic dissection. Okay. All these are signs of end organ damage. All these are very, very important end organ damage. So when a person comes to you with very high BP, say even more than 160 or 100, textbook says more than 180, 120. Okay. But if the BP is still more than 160, 100 and the person has some kind of end organ damage, then you definitely consider this as an hypertensive emergency. So hypertensive urgency is no end organ damage. Emergency is there is end organ damage. Okay. So like I told you, what are the end organ damage that we see? In heart, there can be a left ventricular hypertrophy or decreased diastolic function. To check that, we do the ECG and echocardiography. In the blood vessels, what happens is there is stiffening of the blood vessels. And this is another important thing, that is microangiopathic hemolytic anemia. Okay, microangiopathic hemolytic anemia. Okay, that is hemolytic anemia. This is also an endogen damage where you find hemolysis in the patient after there's an episode of high BP. Okay, this is microangiopathic hemolytic anemia. In the kidney, you will have hyaline arteriosclerosis or hyperplastic arteriosclerosis. Like I told you, there can be renal artery stenosis. Also, you need to remember that is renovascular hypertension. In the retina, they can have hemorrhages and cotton wool spots as well as papilledema. Papilledema means there is definitely endogen damage. Okay, then the brain, there can be stroke or decreased cognition. Okay, and these are all the tests that you will do to find out these endogen damages. So you need, when the person comes to you for diagnosis of hypertension, you should also evaluate and see whether he has any other endogen damage. So when the person comes to you, you should do an ECG and echo to find out if there is any cardiac risk. Okay, you should also assess the state of the kidneys. You should do the creatinine levels. You should monitor the proteinuria and see if there is any proteinuria in that patient. Okay, so you need to find out if the hypertension has affected any other organs or not. This is very, very important when you evaluate a patient. Okay, and you can expect a lot of questions in this. Microangiopathic hemolytic anemia is a very, very favorite exam question, which you have to remember. Okay, so next, coming on, what is resistant hypertension? I already told you, use of 3 drugs and the person's BP is not coming under control. The person's BP not controlled. Okay, so that is called resistant hypertension. What should you keep in mind? You should keep in mind that the person can have secondary hypertension. This is very, very important. Okay, then hypertensive retinopathy. This is also a very, very famous question that you will be asked. They will give you fundus pictures and they will ask you to find out the stage, or they will ask you what is the condition in this patient. So there are 4 stages of hypertensive retinopathy. The first thing what you will see is there will be narrowing of the arterioles. You can see here there will be narrowing of the arterioles. So the first step is arteriolar narrowing. Okay, what is it? Arteriolar narrowing. The second thing is AV nipping. Okay, you can see here you cannot find the ends of the vessels. That is AV nipping. You need to remember these words so that when you find it in the MCQ, you can directly go and take the answers. Okay, so the first stage is arteriolar narrowing. The second stage is arteriolar AV nipping plus the first stage also. Then the third stage will be first stage plus second stage plus cotton wool spots or hemorrhages or retinal hemorrhages. Cotton wool spots or retinal hemorrhages. Okay, the third one will be cotton wool spots or retinal hemorrhages. You need to remember this. The third one will be cotton wool spots or retinal hemorrhages. And the fourth one will be papilledema. What is papilledema? Papilledema is the enlargement of the disc that you see here. You can see here that the disc is normal, but here there is diffuse bulging of the disc. So that is called papilledema. So the first one will be arteriolar narrowing. The second will be arteriolar narrowing plus AV nipping. Third will be 1 plus 2 plus cotton wool spots and hemorrhages, retinal hemorrhages. The fourth one will be 1, 2, 3, 4 plus papilledema. Okay, papilledema is the disc bulge. Okay, so this is very, very important. Once you identify this, you can just directly go and take the stage of the hypertensive retinopathy in those patients. Okay, so I hope you have understood what we have discussed so far. We'll just discuss some questions so that you can just reinforce all these concepts in your mind. Okay, the first question is, a 75-year-old male patient comes with complaints of headache and giddiness to you. His ambulatory blood pressure was recorded and to be in the range of 144 to 150 and 80 to 86 on diastolic blood pressure. What is the likely diagnosis? I would like you all to comment in the chat box so that we can have a discussion. So the BP is in the range of 144, 152 and the diastolic BP is 80 to 86. Okay, so what do you think is the BP? How do you define this? It is grade 1 hypertension, secondary hypertension, isolated systolic hypertension, or masked hypertension? What would you say that this thing is? How do you diagnose this? This, as you can see, this only the systolic blood pressure is elevated. So in this patient, the person has isolated systolic hypertension. Isolated systolic hypertension. Okay. Yes. So moving on to the next question. A 57-year-old male has been diagnosed with hypertension. He has no signs of organ damage, no existing cardiovascular disease with normal renal function. Okay, he has no endogen damage and he has been diagnosed with hypertension. He should be started immediately with antihypertensive medications if his BP is. So when will you start the hypertension? When will you start the patient on BP medications? If it is more than 130/80 or more than 140/90, more than 150/100 or more than 160/100, when will you definitely start the patient on antihypertensives? I told you, you would start the patient definitely on antihypertensives if the BP is more than 140/80. But in this question, you will see that the more appropriate answer is more than 160/100. Because if the person has more than 160/100, you will definitely start the patient on medications. Okay, 140/90 is the cutoff. But if the patient comes to you with 160/90 or 160/100, you will definitely start the patient on medications. So for this question, the more appropriate answer would be 160 on 100 millimeters mercury. Okay. Then the next question. A 68-year-old gentleman, a known hypertensive since 10 years, comes for review. His BP is 170/100 millimeters mercury. His serum creatinine is 1.5 milligram per deciliter with protein of 2+ in the urine. What is the preferred combination of antihypertensives? So this patient has hypertension, okay, increased creatinine and also proteinuria. Okay, so once you see this hypertension plus proteinuria, the first preferred drug would be AC inhibitor or ARB. So this is how your questions will be framed, and you have to just identify the key points so that you will be able to identify the answers. You will be able to answer very easily, and you don't have to waste your time going through all the things. Okay, so hypertension plus proteinuria, the first line will be AC inhibitors and ARBs. Okay, then coming to the question that we discussed first. Sorry, there's a typing error. This 25-year-old lady. The 25-year-old lady with no significant past medical history came to the clinic for follow-up. Her serial BP recordings are 160 on 100 millimeters mercury. Cardiac examination is unremarkable, and all the pulses are full and equal. There are no signs of peripheral edema. On lab evaluation, plasma renin activity is found to be low. Serum creatinine levels are normal. On CT abdomen, there is enlargement of the adrenal glands. Okay, so what will the sodium, potassium, and pH be? So this is a young lady. So when there is a young lady with hypertension, what would you think of? You need to think about a cause of secondary hypertension. Okay, so secondary hypertension is very, very common in the young patients. So our BP is also high. And you find that there is no cardiovascular problems. The cardiac examination is normal. There is no signs of peripheral edema. That means there is no renal involvement. The creatinine levels are also normal. So that means there is no renal involvement. And there is no edema also. There is no renal involvement. The renal and cardiac are cleared. But what are the positive findings that you have? The plasma renin activity is low. The plasma renin activity is low. And there is enlargement of the adrenal glands. This points out towards primary hyperaldosteronism. Okay. Primary hyperaldosteronism. Okay. What is this? Primary hyperaldosteronism. Okay. Primary hyperaldosteronism. So what happens in these patients? What is the function of aldosterone? Aldosterone actually reabsorbs sodium and water. Aldosterone. Let's see how to arrive at this answer. So the first is aldosterone will actually reabsorb sodium and water. Okay, isn't it? Reabsorb sodium and water. That is the function of aldosterone. So what happens when sodium is absorbed? In return, because of the sodium getting reabsorbed into the cell, okay, say this is a renal cell. So sodium gets absorbed into the cell. What happens is there is a lot of negative charge. So to neutralize this, the renal cells secrete potassium. Okay, so because of the potassium loss, there will also be some hydrogen loss. So for every sodium that is getting absorbed into the system, potassium and hydrogen will be excreted out. So what did I say? That is because of sodium aldosterone, the body reabsorbs sodium and water. Okay, as a process, because of this process, potassium and hydrogen are excreted. For every sodium that is reabsorbed, potassium and hydrogen will be excreted. So what happens? Because of the potassium going out, there will be hypokalemia. Okay, hypokalemia. So the potassium levels will be less. Okay, where do we find the potassium level is low? These are the three options that we have, that the potassium level is low. Okay, so because the hydrogen is getting excreted, what will happen? The pH will be increased. Because of the loss of hydrogen, the pH will be increased. That will be more alkaline. So the pH will be high. So we have these two options now, C or D. We need to find out whether the sodium will be low or normal. Okay, you may think that because the sodium is getting reabsorbed, the sodium levels will be high. But that is not the case, because there is an increase in the, when along with sodium, water is also getting reabsorbed, because along with sodium, water also gets reabsorbed. So the intravascular volume will be increased. So the volume inside the body will increase. So because of the sodium and water reabsorption, the intravascular volume will increase. What happens? The intravascular volume will increase. So this will actually release the atrial natriuretic peptides. What will happen? When there is increased venous return to the heart, the atrial natriuretic peptide will be released. So sodium will also be excreted to some amount. Okay. So sodium will also be excreted to some amount. So because of the intravascular volume increase, because of sodium and water reabsorption by aldosterone, the cardiac output, the venous return to the heart will increase. That will release the atrial natriuretic peptide. This will actually cause the natriuresis. Natriuresis means sodium will be lost. So because of this increase and decrease will be balanced, and the sodium levels will remain normal. So this is the correct option. In a patient with primary hyperaldosteronism, the sodium levels will be normal, but the potassium levels will be low and the pH will be high. So there will be hypokalemic metabolic alkalosis. Okay, you may think that this is a very big question which you may not likely get, but just trust me, this is a very nice question, and you will likely have it in your next exam. Okay, and this is a very important concept to understand also. So you must keep in mind that secondary hypertension is very important. You need to find out, appropriate points which are actually directing you in case of the question, like plasma inactivity or the Cushing syndrome features like purple striae, moon phase, buffalo hump, all those things. Okay, all these things are very important. It will help you in answering the questions easily. Okay, I hope this session was easy and if understandable for you. If you have any doubts, you can ask me.
Thank you, ma'am. It was really a wonderful session. I think some of them were also answering in the session. In the meantime, I was seeing some of them were also answering.
Actually, the messages are not appearing to me.
Actually, not in the Zoom, ma'am. You can actually go to
the YouTube channel only. I'm not able to.
Kavya, Indian Tamil, Purna Chandran, there are Madhumita, Vasa, Allan. Some of them have answered, ma'am.
Okay. Thank you so much for the response. But actually, I'm sorry I was not able to interact because I was not able to see the messages.
Okay, sure, ma'am. Next time we will make sure what we can do, ma'am. Yeah. And thank you so much for all for joining with us today. I think around 170 have joined in the towards the end of the session. 170 have joined totally. Really so good. Thank you so much. We will make sure that more number of people try to actively participate and interact so that the session will be made interesting. And we will also have a test and discussion which can be kept at the middle. We will be trying to do that also. And thank you so much for joining with us. So as I told you at the beginning itself, whatever be the exam, be it next or be it need, try to prepare yourself by the concepts, and we are there for you to help you all too. Thank you so much, ma'am, in spite of your busy schedule, joining with us today.
My pleasure. I would like more of you to come and join so that you can benefit from these sessions and keep it more interactive.
Sure, ma'am. Thank you, ma'am. We will make sure that there is an interaction in the upcoming sessions, ma'am.
Yeah, definitely. Thank you.